Hi, everyone. Welcome to this month's Lunch and Learn. I'm Casey. So I'm going to introduce you to the two people who will be doing all the talking. We have Dr. Brent Agin. He's been working in functional medicine his whole career. It's been over 20 years. And while obviously he loves working with patients, really teaching providers is his true passion. So that's why we started doing this. He could just answer any questions you have from protocols or how to deal with difficult patients to how to get things started in your practice. And then with him is, like I said earlier, Kathy. She has been working with him for, I believe it's over 15 years, right, Kathy?
Over 20,
Over
20
Over
20.
20.
Oh
plus.
my gosh. So, like I say, Kathy is his right hand person, and they work so well together. So, I believe we're going to start with our focus question. Dr. Reagan, you want me to go ahead and I'll pull that up and I can read it for you?
Either way,
So,
that's
all right.
great.
So, just and then, of course, after this focus question, it's open to all questions. Please feel free to type it in the chat. Obviously, we would love to hear you and see you, but typing in the chat works just fine. You can text it to us however you'd like. But the focus question we're going to start with is when a patient fails GLP-1 therapy, what are the most common underlying reasons, and how do you adjust your approach?
Perfect. So, with that being said, this is a great topic. Obviously, in our practice, we deal with a lot of people that are interested in GLP-1s, that are on GLP-1s, that have come to us from being on these medications from other clinics and then coming to us for various reasons. And so, when you look at the data on these medications, it really two things. One is you can't really deny having information and education about them, and you definitely can't deny the future of where GLP-1 peptides are going because currently the statistics are is that about 20% of the population has tried them at least once. I think it's more like 30%, but and then right now there's about 15% of the population are on them. As you can imagine, women are 70% of the users. So definitely more than men users of GLP-1s. And what's interesting is that the average age of use of these peptides is 50 to 64. So that is the most common out of the users of GLP-1s, which becomes very important as we get into this discussion. So, as we kind of look about, when people plateau or fail, you also have to start with at least initially thinking about why did these people gain weight in the first place? And, I don't think we spend enough time on really understanding why they got to the weight they did, especially in some of the functional medicine clinics or clinics that are really focused on weight loss. Some of the med spas, they're more of a weight loss clinic than a functional medicine clinic. So when you think about that, you can see how this could play into what the type of plateaus that and failures people might come across. So, you know, just kind of in looking at the GLP-1s in general, there's two kind of different patients you're looking at. They're the ones that have food problems. They're overeating, they're snacking, they have food noise. Food is definitely the problem that has led to obesity. And then you have others that have stubborn weight and they might have a decent lifestyle. They just for some reason aren't successful losing weight. It gets frustrating, it gets emotional. But you can see already the two of them are very different. So, we'll talk a little bit more about what led them to the obesity at the end, but you kind of see these two different patients. You have ones that are really having an eating problem. It's very clear. They overeat, they don't have an understanding of the food groups that they're supposed to be eating, they're not exercising, they have food noise, they're snacking, processed foods. Very understandable why they would gain weight. And then they have the others that have stubborn weight. They're trying to do what's right, and they're having problems losing weight. So as you start to get into these patients that are using the GLP-1 peptides, you kind of look at them in three different groups. They're the ones that it's about 20%, 30%. The ones that they start off, they lose weight great. They have minimal side effects. Everything seems to be going really wonderful for them. And it seems magical. I mean, this is transformational, opportunity for these patients. Then you have the majority of the group, which is about 50%, that start off pretty strong. They get a good, nice surge of weight loss, and then they just slowly start plateauing. And that's the majority of the people. And then you have this other group that, that just, they're the ones that come in and say, I've been on it for 3 or 4 months and I haven't lost a pound. I actually gained a pound, or I've lost 4 pounds in 4 months. So you start looking, and so those patients, obviously is a red flag from the beginning. And so when you look at how or why these people are plateauing, you're going to think of two different ways to approach it. And I'm hoping most of the people that are listening are looking at it through a functional medicine lens and not just a obesity clinic or a weight loss lens, because they're two different approaches. So as people plateau, you have these three different groups to kind of consider. And so the knee-jerk reaction is to think, okay, if someone plateaued, we need to either increase the medicine or change the medicine. And that's not a bad approach, but you have to consider each of these three groups and then understand what you're going to do when they do plateau. So let's just identify them. So you have the first one that is someone that just very quick results. They're doing great. You have to assume these people are losing weight because what do GLP-1s do? They help people reduce their appetite. They help decrease peristalsis or GI transit. They take away food noise and they create this great opportunity for weight loss. So in that first group that is just overeating, they have the food noise, they're snacking, they have a definitive reason linked to their weight gain or their obesity or their being overweight. These people are going to do great on GLP-1s, and those are the ones that if they're on semaglutide, you could obviously make a transition into increasing the dose or looking at making a transition into tirzepatide. And then obviously from tirzepatide people, if those people plateau, a lot of people then transition them onto retatrutide. And really what you're doing is just adding metabolic opportunities through the drug classes. So that makes sense. Now you have this other group that starts out where they have initial response, they're losing weight, and then they kind of hit a wall and they start plateauing. So the knee-jerk reaction again is, well, how much are they taking? Are they on tirzepatide or are they on semaglutide? If they're on semaglutide, you usually transition them up, or you convert them over to tirzepatide, and that's fine. But as that middle group that initially was losing weight and then plateaued, you have to start thinking a little bit from the functional medicine side. So what is exactly going on? And all of them will potentially end up in the same place. Then that third group that didn't lose any weight. These are the ones that have 3 to 4 months, they haven't lost really much weight. They're frustrated. Almost all of them will have a decrease in appetite, but these people are still not losing weight. And then you have to think of all of these three groups, which are the ones that are still exercising, hitting their protein goals? Are they taking the drug the right way? Are they taking the right dose? Are they injecting correctly? Are they consistent with their dose? And are they having side effects? So when you consider all of these factors, it starts to give you kind of an approach to the people that are plateauing. But each of them have a different reason to plateau. The first group is that's overeating. If they've decreased their food noise and they've lost a significant amount of weight, greater than 10 to 20% of their weight loss, then those are the ones that you can make some medication shifts. But you have to start realizing that most of these people, when you're not eating enough, that you still could end up into this conservation mode, which is a nervous system situation. The ones at the end, the ones that never lost weight, those are the ones, again, remember the average age of patients that are using GLP-1s are 50 to 64. So these women are already in menopause, either perimenopause, they're in menopause, or they're postmenopausal. So just imagine taking one of these people that, as I said before, that might not have had a lot of food noise, might not have been overeating, but still can't lose weight even on 3 to 4 months of GLP-1s. Well, that's an immediate signal that there's something biologically going on with these people, and the GLP-1 peptide wasn't the solution because they likely had a cortisol, thyroid hormone, circadian rhythm disorder, not just a blood sugar problem. And so any of these patients that start to plateau, you have to start thinking through that logic is how long were they on the medicine? Could I switch to a different drug, which is fine. That's the pharmaceutical route. Could I switch them from tirzepatide to retatrutide? Yes, you can. But you have to start digging into some of the biology at that point when you hit a plateau. So no matter how you look at these three groups, the first one loses a bunch of weight, then they stall. The second group loses a little bit of weight, then they stall. The third group doesn't lose any weight at all. All of these women, normally, because again, we're talking that the majority of the people using these are women, these patients in general, they're all kind of ending up at the same point where you're starting to have to look and saying, okay, I can just keep playing the pharmacological game and just changing their medications or increasing the amounts of the medication they're on, or you can start digging into the biology. And of course, my approach is always the biology, and that's how I kind of start. You should look at these statistics and understand that it should make you start considering understanding a little bit more why they gain the weight from the beginning than waiting and putting them on a GLP-1 and seeing which category these people end up in. Are they a fast loser, a plateauer in the middle, or someone that doesn't lose weight at all? Because all of them likely have some sort of biological component to what caused their obesity in the first place. So as you hit these plateau patients, this is where you really have to start looking at what your end goal is. If you're just a turn and burn weight loss clinic or obesity clinic, yeah, you're going to be doing the pharmacological route a lot because unfortunately, that's what patients want. They immediately think that this is a medication problem. Do I need to go up on my dose? Can I try one of the other drugs? Can I go on to retatrutide? And this is where it gets dangerous because, as you know, the long-term studies on these drugs for weight loss specifically are not there. But what we do know is that most of the patients that we have are not on hormones. Most of
Yep.
them are not metabolically healthy because we know 20% of the population is not metabolically healthy. We know most of the populations aren't using hormones, and then 80% of the population is overweight. So if you're looking to get a clinic that uses GLP-1s the correct way,
Can I help you?
then you're going to have to start looking at what caused their weight gain in the first place. That's going to be the starting point, not getting them on the medicines and then
Mhm.
trying to figure out why they're failing the medicines or why they're plateauing at that point. So a typical approach is going to be, first finding out where they're at. Do you know why they gained their weight in the first place? And if you don't have a solid knowledge of that, then you have to see where they are on their medications. Did they start with semaglutide? Did they start with tirzepatide? Or did they start with retatrutide? That's going to allow you to at least start saying, are these people microdosing? And do I have an opportunity to increase their dose? And does increasing the dose make sense based off of the early responders, the plateauers, or the people that didn't lose any weight in the first 3 or 4 months, anyways. So you can kind of see that you're starting to build out which of these people obviously have a different cause of weight gain other than just insulin itself, or the ones that might have been mixed. They had some appetite problem, maybe some overeating, and definitively some insulin problems in the beginning. And then you have the ones that obviously, if they didn't lose any weight at all on a GLP-1, there was biology was the driver. That means these are the ones that it could be cortisol, it could be hormones, it could be their circadian rhythm, it could be their gastrointestinal dysfunction. A lot of different, not exercising, lean muscle mass loss. Because again, remember, these are the average woman using these are age 50 to 64. So at the end of the day, you can kind of then, as these people are still all start plateauing, they all start forming into the same type of client. They're all getting into a point because if you're losing weight initially aggressively, whether it was, right out of the gate, or you're ones that lost some weight and then plateaued a little bit earlier, the same thing is happening. When you start, when the average patient is not tracking their caloric intake, tracking their macronutrients, tracking their micronutrients, and potentially either overexerting themselves on a low caloric intake or not exercising all and letting the drug do the job on its own. Any way you look at it, they're going to start getting into conservation mode. And so what happens when these people plateau is just the same way that we would look at some of these women had they never went on a GLP-1. They're already in that spot. These are people that already likely are not losing weight because their hormones are off and they never got put on hormone replacement. Their sleep is off, their digestion is off, and you have opportunities to start correcting it before they even got on the GLP-1s in the first place. But once they're on and they plateau, you definitively have to start taking these people on as a functional medicine patient and start doing the right diagnostics to see if you can help them. Changing the drug is not necessarily going to be the solution. It might change it initially, and you might start getting, you break the plateau and you might start getting weight loss. But if you don't have the criteria in the data, it's going to be very hard for you to help them. And again, remember, you don't just want someone out there that's losing weight, has a sunken face, they're losing their muscle mass, which a majority of the people lose 20 to 40% of their muscle in their total caloric loss. You want that patient that's going to be using the GLP-1 correctly, losing weight progressively, and being able to either sustain it on a microdose with a good lifestyle or transition them off of them. So the decision making becomes pretty simple. You get these people and they start plateauing. They come in, you have to ascertain what drug they're on, and then you have to you start having to consider getting lab data. Of course, from my view, is that all of these people deserve labs. I mean, if you're going to start someone on a GLP-1 that's between the ages of 50 and 64 as at average, or even go down to 40, why not get a snapshot of the labs before they start? So at least you're ready or prepared to manage the plateau because it's going to come. Only 20% of GLP-1 users lose their weight, maintain their weight, whether they stay on the drug or they taper off of it, that use it successfully. The rest of them will eventually start to get into that compensatory mechanisms of the body and what the nervous system's naturally going to do. So you have to, so getting labs at the beginning is a very solid response so that you basically, as a functional medicine provider, again, you're getting the data up front so you can support the journey as they're going through this process. And even as you identify where they might be in that GLP-1 use, whether they lose weight quick, they plateau early, or they don't have any weight loss, you have the data already before they started down this pathway. So you have a good baseline so that you can start implementing the changes necessary. So just a little kind of to summarize this thing. When you're dealing with women that already have weight that they can't get off, chances are they're already in some sort of a sympathetic dominance, meaning that the nervous system is already working against them. So when you put someone in a caloric deficit, you lose some of their lean muscle mass, they're not exercising, you start getting into this conservation mode, which starts changing the internal hormones and also changing the way the neurotransmitters are being fired. So just imagine if you already had one of these women that went 4 months on a GLP-1 and only had 3 to 4 pounds of weight loss in that age bracket, you're potentially adding fuel to the fire. You already have someone that's in sympathetic dominance, survival mode. Now you're putting into a caloric deficit. So you're increasing their cortisol, they're decreasing they're changing their thyroid. You're basically decreasing free T3, increasing reverse T3. You're decreasing testosterone, you're decreasing progesterone, you're decreasing estrogen. This is all happening behind the scenes, and then it makes sense a little bit of why someone would be plateauing or failing GLP-1s in the first place. The other two categories are eventually going to end up in the same spot. And that's the nice thing is that the way you're going to manage these plateaus are all the same. It's just some of them might have had better success in the beginning, but you're still dealing with someone that is now stuck. So when they become stuck, whether out of any of those different three categories, you're now going to have to deal with what's the next step. I plateaued, my weight loss has stopped. What do I do, doctor? And that's where you're going to have to say, okay, well, you can either do, like I said, obesity clinic or some of the med spas that are not really using functional medicine. They're only going to play around with medications, which is, it's okay if that's all the tools you have. But remember, that's not how we're trained. We're trained to try to get to the root cause and realize that obesity is for people that don't have an eating problem. Obesity is very complex. It has a lot of different factors that are involved in causing this situation. And so to kind of circle back is that you got a patient, they started on GLP-1s and now they're at a plateau. They either came here because they lost a lot of weight initially and now they slowed down and they're frustrated because they still have weight to lose. Or you have one that lost a little bit of weight initially and then they plateaued. And then you have the third one that didn't lose any weight pretty much at all. And they're all in your office now saying, what do I do next? Well, all three of them, there are signs that there is biology involved in this. It just isn't a medication deficiency or a medication problem. These are signs that there's something going on internally that is causing the plateau or causing the lack of weight loss success. So you just have to kind of think of that and then start approaching GLP-1s from a more of a functional medicine lens, and you're going to have way better outcomes. It might be slower, it might not be as robust, but it still can be life-changing and it still can get to the same results. You're just tiptoeing around these plateaus and hopefully working through this a little bit better because you're adding the biology at the beginning. Now, don't get me wrong, these patients that have the eating problems, they're overeating, the food noise, they've never been able to manage their weight their whole lives. These people, this is magical for them. This is the magic pill that they've never had. That is completely fine, but they will end up in a situation if they do not start at some point learning how to eat, managing their caloric intake, tracking their micronutrients and macronutrients, and somewhat addressing their hormones. Because you could take someone that was overweight, but not with an intact nervous system and intact hormones, and put them into a hormonal deficiency or survival mode very quickly by too quick of weight loss or not addressing their plateaus correctly. Because usually the plateau is saying something is internally wrong, not change my medication. It is basically saying my body is compensating because I am in a caloric deficit and my sympathetic nervous system is revving based off of this. That's what happens when you're not eating enough calories. Your body starts saying, well, wait a minute, we don't have enough reserves. It starts affecting the way your blood sugars, your hormones for sugar metabolism are released. It starts, like I said, affecting all of your androgens. It starts affecting your thyroid. It starts shifting into cortisol, hypercortisolism. It starts lowering your DHEA, lowering your pregnenolone, and obviously this starts affecting your neurotransmitters as well. And remember, GLP-1s also affect the gut. So now you're also having a slower peristalsis and changes with heart rate variability and vagal tone because of the nature of the drug, which then also affects serotonin, dopamine, and then obviously you can start getting when your dopamine system's being affected or dysregulated. Now you're also dealing with the risk of anhedonia or dysthymia, which is now becoming a pretty common complaint or symptom that people are having because they don't expect the way these drugs can affect mood. And they're already doing research right now on all of the GLP-1s, especially tirzepatide, for helping with substance abuse and addiction in general. So there's a dopaminergic component to this whole thing. So when you start playing with dopamine systems, you are risking between the caloric deficit and the way it works on your dopamine systems that you are putting someone at a higher risk of having depression or
That
even
was
potentially
interesting.
So now I'm on my laptop. So sorry about that, everybody. Can everyone hear me still?
Yep.
We can hear you, yes.
All right, perfect. So where I left off is that I'm hoping that people are starting to understand this pattern, because the more you understand the pattern, the better you're going to take care of the patients that you have that want to be on GLP-1s that are looking for weight loss, because there is a functional medicine approach to it that makes sense, and that is using functional medicine as we always have to understand why people might plateau and so when people plateau is understanding and listening to the reason people start going into conservation mode. You can't immediately think that you have to start changing medications. You're going to have to start digging into the biology. The best thing is to have that basic lab or the comprehensive lab panel as they start so that you can already have an understanding of where their hormones are and also understanding what you're going to be able to do if someone plateaus. The second thing is remember, they plateau. You can make your medication changes if that's what you want to do, but you also have to start making sure that the people's getting adequate protein. Are they on a micronutrient supplement? And also, are they tracking their macronutrients and caloric intake? You really cannot assess someone that plateaus without having that data. So you don't want to get into the habit of just completely taking people that plateau and just immediately wanting to switch their medications. You have to start digging into the why, and that is, in most cases, is going to be the conservation mode that the patient starts going into. And I'm sure you can kind of see how that whole picture works. And this is very similar to someone that comes into your office that is just toasted. They come in, they can't sleep. They're gaining weight in the midriff area. They're tired. They can't get any response in the gym. They look like they're losing muscle mass. Just they can't make any sense out of anything. And before we didn't have a lot of tools, especially because hormones were not looked at as so positively. But now that we have the ability to push hormones on our patients, you have to start looking at ways that we can pull people out of their plateaus without potentially putting them farther into the hole. So I like to take the opportunity when people plateau is to start saying, well, wait a minute, it's not the medication that's failing. Let's take a look at what is causing your body to hold on to weight. And again, it's very logical once you start putting it all together, because once you start dropping calories, you start reducing hormones, you start losing lean muscle mass, you're already putting yourself into a more of a metabolic hole than you were before you started in some of these cases. And so please get out of the habits of always just adjusting medications and start looking through it, like I said, through a functional medicine lens, so to where you can actually start providing real solutions and getting these people to be your success patients, not ones that end up, just plateauing and then just stopping the drug, either due to cost, either due to depression, either due to lean muscle mass loss, or of course the ones that haven't figured out how to manage their food noise and eating strategies. So so hopefully that all makes sense. I don't know. I kind of got thrown off a little bit by the power outage. Uh, so so does anyone have any specific questions about that whole process? It might be easier to answer questions about it than me to go back through part of what I'm not sure if I covered when the electricity went out.
Right. No, I think so Tiffany, while you were out, I was asking yeah, everyone here, are there any questions up till now? And so Tiffany had written, will he be going over how to implement functional medicine for the patient that plateaus? And then she wanted to know, what labs do you recommend?
Yeah.
If the patient will do labs, what labs to do prior to starting GLP-1? And then are there any labs for when they plateau?
Yeah, so the labs are going to be the same. Getting a baseline comprehensive hormone panel. You want to get as many micronutrients as you can. You don't have to do a micronutrient test, which is hard and long, takes a long time and it's expensive. But the main labs you're going to want to get is a complete metabolic panel, a CBC. You're going to want to get a free T3, free T4, reverse T3, and a TSH. TSH doesn't matter as much. You're going to want to get all the hormones, IGF-1. You're going to want to get a DHEA, pregnenolone, free and total testosterone, all three estrogens if possible, and a progesterone level, and iron, ferritin, TIBC, and Kathy, am I forgetting any?
That's that's pretty much about it. Those are the most important ones.
Yeah, so that's the initial panel that's going to make the most sense. And I'll at the end I'll kind of speak about a little program that we're doing so you guys kind of understand that. But those are the main labs. And so when someone plateaus, usually what's happening in the majority of cases is that once you start, if you're not tracking your calories and you're not getting in your target protein intake, which is again why you're probably under caloric as well, the body compensates. It's very smart when it's not getting enough energy, and it will take energy from anywhere. And that is its job. Its job is to protect vital organs, to protect the brain, and it will compensate. And so when someone starts to plateau, especially with GLP-1 meds, is because the appetite reduction can be so strong for some people. So just imagine if you either of those three categories, you were someone that just was overeating, you were someone that was overeating a little bit, but just had some stubborn weight, or you're one of those people that just didn't lose any weight at all.
Hi, TikTok.
What's that?
Oh, I'm not sure.
No.
Keep going, Dr. Agin. I'm sorry. I'm not sure what happened there.
Oh, so anyway, So all of these people, you know, are eventually going to, when compensation happens. So answering the question is what you're supposed to do is you look at your hormone panel, and this is where you start understanding that as soon as you know more, once you have the hormone panel, the more important details are also going to be the food diary. You need to know how much calories they're getting in. If people are sub 1,000 calories every single day and not getting enough protein, they're basically putting themselves into sympathetic tone or sympathetic stress. And this is where they call it survival mode or conservation mode. This is where your body's nervous system is going to respond and start making changes based off of what you are putting it in metabolically. That means it's going to start changing the way thyroid is converted from T4 to T3. It's going to convert from T4 into T3 and actually convert into reverse T3, which is basically a metabolic break. Also, what's going to happen, you're going to start having your testosterone rate reduce. You're going to have your DHEA and pregnenolone go down because they're being utilized to make cortisol. And you're going to get your cortisol is going to go up because your nervous system is constantly revving because you haven't given it enough fuel to actually bounce back and forth between parasympathetic nervous system and sympathetic nervous system. So you're in cortisol dominance. And that affects progesterone, that affects estrogen, which then starts affecting mood, then starts affecting sleep. And when all of those factors are in place, you're basically in this vicious cycle. And then unfortunately, what happens is most of the time when women stop losing weight, or they even start seeing that they're putting weight gain, especially in the midriff, they start to feel like they even need to eat less and work out harder. When they eat less and work out harder, the working out is even more of a stress on the body, driving that sympathetic dominance even more and putting people even further into the rears. And this is when people start seeing that their hair's falling out, their nails are brittle, their skin's looking rough, they start to look flabby, their triceps are starting to look like they have no mass at all, and it's a very confusing scenario. So just imagine if you, as a physician, took that patient and said, "Okay, well, let's just increase your dose," or "Hey, let's just move you on to retatrutide," which you know seems like a logical path from a pharmaceutical aspect, but remember, retatrutide is a very interesting drug the way it works, and again, and that's why it's still investigational, and that's why it's still potentially very risky to put a woman the age of 50 to 64 that's already plateaued. So you're already getting signals that there's something going on with biologically, and then you switch them to a new GLP-1 that potentially shortcuts even further by the way it affects glucagon, and now you're potentially even confusing the body even more. So the message is just take your time. If these people do not want to take their time, does not mean you have to practice outside of what you feel is the right scope. And Kathy and I do this all the time. It's just because someone wants something and they want to see if they can take a shortcut doesn't mean it's the right way for the patient. And you're going to find that more and more and more, this is the way you can approach and view these people, and you're going to see them completely differently when you understand how the body compensates. And so the faster you learn this, the faster you're going to even change the way you approach putting people on on these drugs in the first place. Take your time to figure out exactly where you think these people are going to fit in. Are they overeaters, too much food noise, too much snacking, poor lifestyle? Are these people that are working hard and just have stubborn fat, and you're just and they've done everything right and they just can't lose weight? They're emotional. That's still a sign there's something wrong. And then there's the ones that obviously that come in and that you can tell they're already in some sort of a hormonal decline and sympathetic dominance. Those are the ones you have to be very careful about. All of them can respond to a GLP-1. That's the thing to understand, is if you put any of these people on a GLP-1, they may lose some weight. But most of it, remember, that's just that last category that just has no weight loss because they're already at a point where biology was their problem. It wasn't food, it wasn't insulin, it was hormone decline, cortisol dominance, and sympathetic dominance. So just get better at recognizing where these people are at in their weight loss journey as they come in to see you, so that you can potentially stop them from getting into a plateau and hopefully guiding them through their weight loss journey a little bit more eloquently. So So hopefully that all makes sense. And so when they do plateau, you're going to be doing hormone optimization, micronutrient correction, because again, they're micronutrient deficient almost surely. They're macronutrient deficient almost surely, and they're hormone deficient. All three of those things then affect the mood, affect the gut, and affect their sleep. So as you start making hormone changes, micronutrient changes, which is the heart of what functional medicine does, get them focusing on their sleep to help stabilize their nervous system, and then getting them exercising, but you may be actually pulling them out of resistance training and getting them to do a little bit more conservative exercise, but get them moving their body somewhat. That's going to be the approach. And so if you approach them this way, you're going to find one, they appreciate that you're putting some science into it and not just playing around with drugs. And also, you're going to put them in a better position to be able to taper off the drug in the future, which is in my mind key. I know that there are some doctors that say that their patients, they'll leave them on GLP-1s for life if they have to be. That's not my approach, and maybe that'll change in the future. But right now, there's definitely not enough data to approach anyone that way to think that this is the right position is to take someone that had never used any of these drugs and say, okay, now we found a drug that you're going to be on the rest of your life. Because it is very dangerous, again, with that category that's dominating this medication usage is a category of people that are already susceptible to cortisol, hypercortisolism, and sympathetic dominance. And that's already you're kind of playing with fire with some of these clients. And if you don't identify it early, it can end up being a bigger hole to get out of it than the obesity problem was at the beginning. So hopefully that makes sense. And I want to have some time for questions because I know this is a very popular scenario right now is helping these people guide these people through their plateaus. So Kathy, did you have anything to add since you talk to way more patients than I do on the phone about GLP-1s? Is that anything you want to add or is pretty
No, I
consistent?
mean, that's very, very correct in everything that you said. I mean, those are the categories. And I mean, I speak to women all the time regarding they'll hit plateaus. And it's difficult, and they do. They want to switch to another GLP. And so I try to explain to them that they really need their hormones looked at. That they can switch, but chances are they're going to have the same issues. And of course, like you said, it's very important to be able to identify where their weight comes from as well. So that's an extremely important conversation to have with someone right off from the beginning.
Yeah, and so the way we approach people, especially, and again, I'm going to keep this age group because this is the one that's dominating the category of drug use, is we'll even say 45 to 65.
Yeah.
Is when you approach those 45 to 65-year-old patients, whether men or women, remember what is happening after the age of 35? Hormone decline. What do we know that's going on with our population? 80% is metabolically unhealthy. So just the fact that they're in hormone decline, metabolically unhealthy, you have to consider hormone panel right at the beginning. And this is what's going to differentiate your clinic from an obesity clinic or a weight loss clinic that is really just pushing these products. We get patients that come into us that are getting GLP-1s from other centers, and they're doing it a little aggressively, and they're not looking at what caused the weight gain, and they're definitely not looking at what could be causing the plateaus. They're only playing around with the medications. And that is where you can shine, and you can get a lot of these people that are leaving other clinics or they're getting it online and they're coming to you for solutions. This is how you're going to solve their problems. And it's going to be explaining it exactly the way we just talked about. And so this is like, let's go back before the time of GLP-1s. This is what we were dealing with. If people had obesity, this is how we approached them. Yeah, we could use weight loss. We could help with weight loss, but we were helping people with weight loss, maybe a little bit of phentermine to help with the food noise and the cravings. But that would be for 2 weeks to a month. And then everything else was done through functional medicine. It was the GLP-1s that have basically come in and are replacing what we would normally need to do in lifestyle to get the same result. The problem is when you do it through functional medicine, you don't end up worsening your sympathetic nervous system inflexibility and start putting people into more of a hormone deficiency state. So once you kind of recognize these patients and how they're coming in and which one they were, where they fit in that plateau, you're going to be way more ready to help them get out of it. The earlier you have the hormone panel, easier it is going to be for you to bring them in and say, hey, this is what we need. And again, remember, we have support that is telling us that we should be pushing hormones onto this group of women. And before it was a little taboo, but now it's out there. People are asking about it, people are talking about it. Women are wanting to get on hormones now. So this is the perfect time to do it in conjunction with a GLP-1, in the transition off of a GLP-1, or in place of the GLP-1. So again, don't this is a huge topic because it's not going anywhere, at least anywhere soon. More and more people, if it's already at 20 to 25% of the population has tried one, or 30%, that's not going to change. And especially for women, unfortunately, because women struggle with it. This is a huge problem. And when we didn't have the opportunity to use hormones, it was even a bigger problem. But in non-traditional medicine, we've been using hormones since we got started in functional medicine, but that's not the norm. So you're going to have all of these patients out there in traditional medicine that are on GLP-1s with their primary care doctor or their OBGYN or a med spa or an IV center that are getting put on these GLP-1s with no functional medicine background. That's the problem. These people are all going to be looking for solutions, and understanding the cycle that they're in is going to help you be able to get them out of it. And they're going to appreciate you. That's going to be the real testimonials, is them going and saying, "Oh my gosh, I feel so much better because I actually got hormones, and my weight loss was actually causing a lot of these problems, and I had no idea why I was losing my hair. My nails were brittle. I couldn't sleep. I had no pleasure." So the more you kind of understand and dig into this, the better you're gonna get results, and you're gonna have a lot of people coming to you, because once someone tells someone, "Hey, go to this place, they're doing things the right way," you're gonna get, eventually these people are gonna have to get a solution, because GLP-1s without doing it correctly are eventually going to plateau or fail.
Thank you, Dr. Agin. And then I had a few questions on here. I was going to ask if you or Kathy could type the labs into the chat, because they were trying to write them down. You guys were
Yeah,
listening.
we can actually give you like a Word document or a sheet that you can send everybody that has it has our comprehensives, and then the basic follow-up panels that we do after the comprehensives.
Okay. And then let's see the other question that was in here. Oh, how do you determine the protein intake?
So protein intake is pretty easy, and I hate to say this because that's a whole nother conversation, but just like everything in our food industry, I think that, when you see what they did to the food pyramid, I think we're also in a situation where, protein supplements are out of control right now. And they've always told us to eat, potentially a gram to a gram and a half of protein per pound of body weight, especially if you're young and fit and exercising. That goes down with age. I still think sometimes that we're still pushing too much protein, especially if you're not matching that with the intensity of exercise, or if people are exercising. But in general, it's somewhere between a half a gram and a gram of protein per pound of body weight. So if you're a 200-pound man and you're healthy, fit, working out aggressively, you might look at potentially about 150 grams of protein. So you can get down even to like a half a gram. So if you're a 150-pound woman, you're talking 75 grams of protein per day as a target. And that half a gram is fair. Unless you're really, really working out hard, do you start pushing your protein up? But that's always something you can increase. But if you're starting out with at least getting a half a gram per pound of body weight, that's going to take up most of your caloric intake and allow you to just add on a little bit of carbohydrates and fats around it, non-processed, real foods. That's a good starting point. Kathy, would you agree with that, especially for women?
Yeah, definitely for women. And I mean, when I'm talking to them on the phone about how much protein, I always take into consideration if they're exercising. A 75-year-old woman is not going to need the same amount of protein as a 50-year-old that's extremely active and, physically fit.
Yeah, and that brings up another point is that you're never going to get rid of lifestyle. After the age of 50, exercise becomes the most important lifestyle characteristic for brain health. You're never going to get away from resistance training. And they've done the studies to show that lean muscle mass, especially in your large muscle groups, are a direct correlation to longevity. And what's happening with these GLP-1s is people are losing weight without having to have the lifestyle. And so just think about that. They're losing weight without exercise. And 20 to 40% of the weight loss is generally lean muscle mass. That's definitively taking away your reducing your longevity and putting a stress on the body at a higher level than just exercising without being at a caloric not being at a caloric deficit. So you just really have to think about the lifestyle, your sleep, your diet, your exercise, your hormone optimization, your nutritional supplementation, all have to be in place if you're going to have someone on a GLP-1. And if you establish that from the beginning, when people on a microdose, they don't necessarily change that much of their caloric intake. They're going to decrease their appetite because that's the nature of the drugs, but at least they're not going to decrease it enough to where they're in a very low calorie intake, which is under, I think, 750 calories a day, which now you're definitely getting into conservation mode and you will eventually plateau, or most of your muscle weight loss is going to be, like not most of it, but at least 20 to 50% of it is going to be lean muscle mass, which is obviously counterproductive.
Awesome. So then we had another question, and it was, since you are sampling pregnenolone levels and it is derived from cholesterol before the side chain cleavage, is that level impacted by the use of lipid-lowering drugs?
Yes,
Sorry,
it
it's
is.
in the chat. I want to make sure I read it right.
Yeah, because cholesterol lowering statin drugs stop the production of cholesterol, but actually also that also reduces the amount of coenzyme Q10 produced. But would a statin drug affect pregnenolone DHA? Absolutely.
Wait, make sure there's no other questions in the chat.
Yeah, DHEA and pregnenolone are two hormones that are almost always very, very low when women are in this position. Men too, but mostly women. I mean, when a woman comes in to see us, as you can imagine, the more cortisol you produce, DHEA and pregnenolone, especially DHEA, is a direct balancer of our stress response. And so as you start making more and more cortisol, pregnenolone starts shifting into cortisol production, and you start getting a reduction in DHEA, which balances out your cortisol response. So we have women that come in, and when we do their lab panels, their pregnenolone is zero, and their DHEAs sometimes, you want DHEA levels between 200, we'll say 200 and 300 for women. Could actually go a little bit higher in some people's minds, but they come in and their DHEAs are under 50 and their pregnenolones are almost zero. And, this is, you can't deny this. This is testosterone levels of 7 or 11 when, they should be somewhere between 50 and 100. um, Thyroid T3 levels of like 2. And then the reaction is to say, hey, let's just put people on thyroid medication, which at the beginning to help them get out of this hole and to balance out their nervous system is a good idea. But when people get metabolically healthy, they're not going to keep compensating by reducing their thyroid. Remember, they're reducing their T3 because of the metabolically activity of T3 when their nervous system's already revved up. That's a compensatory mechanism to drop T3 and increase reverse T3 to fill up receptor sites, all in a way to calm down the nervous system. So reducing testosterone, reducing progesterone, reducing estrogen, and reducing thyroid is all the body saying, wait a minute, you're eating yourself up. We're going to start slowing everything down. And as you can imagine, that's just completely opposite of what you want when you're trying to lose weight. So then you're going to start gaining weight, and especially in the midriff area, and it gets very confusing. And like I said, if they don't go see a doctor, they're going to be changing their dosing on their own. Hey, doctor, my appetites come back. That's when I hear the patient say, hey, I need to go up on my medication because my appetites come back. Well, maybe your appetites come back because you need to eat. And so again, you can't just let the patient's drive to lose weight overcome the physiology and the biology that's screaming at you to say, please help me.
Thank you, Dr. Agin. So we only have about 5 minutes left. I don't see any new questions in the chat, so I'm going to go ahead and pull the questions that we had to the side. So we had someone who basically didn't know anything about ketamine therapy. They had asked, why should functional med consider adding ketamine therapy? Like what are the benefits of that? What for someone, this is someone who
Saw the
really hasn't
last
heard about
one.
it before. Yeah.
Saw the last webinar.
Yeah.
Um, so yeah, so like when we talk about this, what I call the modern patient cycle, where you can see that a lot of these people on GLP-1s end up, they end up into this situation where, again, their nervous system is inflexible. Usually in life, the parasympathetic nervous system, which is heal and recover, it never fully engages because you're always in survival mode. You're always just the sympathetic nervous system is going, 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 and it doesn't stop. And eventually people start feeling it. They call it wired and tired, and this is where you're completely shot at that point. That's where your body's revved up, but you're exhausted. And so one of the ways that we approach this is, yes, you can do hormone optimization. You can manage all their hormones. You can start getting them to do a caloric diary so you can get their calories to where they are. But one of the quickest ways to bring down the nervous system and get the nervous system more flexible so that it's actually starting to get into the healing state and the parasympathetic nervous system is ketamine. It's just a quick way to get people to get their nervous systems down and allow and while you're making some of these hormonal changes. And after using ketamine for almost 15 years, there's just nothing quicker for men and women to get their nervous system somewhat balanced out. It brings it down and it allows you to focus on sleep, focus on some of these hormonal changes, get the micronutrients corrected, and help them get their caloric intake manageable. So that they actually have data, so they can say, "Hey, let's focus on a 1,300 calorie a day for right now." Now they have a target. Now you can see what their macro breakdown is. You're adding hormones in. You're making hormone adjustments. You can focus heavily on getting their sleep cycle regulated with good sleep hygiene. But starting with ketamine is also going to help them from having that anhedonia and dysthymia. It's just going to it's going to be like a mental reboot, which gives them the capacity to actually make some of these changes and start getting their lifestyle back in balance versus, getting used to a medication that allows you to completely skip it, if that makes sense.
So then we should have time for at least one more of these questions, and the rest we can just save for the next one. So this one, this was a few. Someone had asked again. I think it was the last webinar or the one before. They were asking how you come up with your pricing structure. If you do the membership subscription based, or do you do the pay per visit?
Yeah, we do pay per visit. We've played around with the idea of memberships. I love memberships. I love subscription models, especially when we're talking provider to provider. It all comes down to utilization, and all the clinics that do subscription models, they're doing very good from a revenue standpoint. As you can imagine, there are a lot of people that join anything. A great example is I joined a car wash, spending $25 a month and realize I'm only washing my car once a month. Well, I might as well just pay the $10 for once a month. That's how gift cards work. That's how subscription everything works. People don't utilize all of the money they're paying, so the business does very well through the subscription model. But sometimes it does. Patients recognize that, and they don't want to commit to a subscription or a membership. So our model is that we do have a pretty good charge for a comprehensive workup. So if someone comes in to see us, they bring their labs in for that initial visit. We have a pretty good fee for that, cash fee for that initial workup, but we give them an hour of our time, and it's a very good use. It's just like going and paying an attorney or an accountant for their time. As a professional giving this type of quality health data, I think it's reasonable. But on the other side of it is that we also make it very easy. We don't do a lot of forced visits. We don't inject the GLP-1s in our office where people have to come in weekly. We're very hands off, but we're very good at explaining, follow up, and then fielding calls along the way. So our model has been very, very well received, and it still can be very, good revenue. You just have to think of how you would like it as a consumer, and also look at your socioeconomic area. If you're in Miami, New York, LA, Scottsdale, it might be a little different than Clearwater, Florida, or some smaller towns that resources are just not as readily available. But that's what I'd look at it as, just really putting a value on time. That's what patients perceive, like the amount of time they get to talk to the provider, the amount of information they get. If you're giving them good information and you're giving them time, they're going to understand the value and understand the cost. It's when they don't get one of the two that they end up getting a little confused.
Awesome. Thank you so much, Dr. Agin and Kathy. Does anyone have any other questions before I believe it's actually our time? Anything else? If not, thank you to everyone for coming. We really appreciate your questions and your participation. Dr. Agin, thank you so much for sharing all your knowledge with us. We really appreciate it.
Sorry about the power outage. That was strange.
There,
I
there
mean,
was an incident that happened not far from here, and they
Oh,
just
oh,
had 2,500 people. There was explosions down by the on top of the world, which
oh,
triggered 2,500 outages. So that's probably what it was.
wow. At least we still have power.
Yeah.
Might have some computers now, but
oh, goodness. Well, thank you, everyone. We
all right,
appreciate you
thank
all
you
coming.
all.